Dr. Sadipan, and thanks for the very kind invitation to invite me to speak at the Society for Eczema Studies. And thank you, Dr. Jayaka Thomas, for that great talk on topicals. I think setting up this society is definitely wonderful. I mean, I do echo what you say about, a lot of times, a lot of these studies are done in Caucasian populations in Europe and US, and occasionally in Korea and Japan, and we really don't have studies in other populations in Asia. And, from the talks that I give and comparing with other populations, you do find that sometimes our patients do react differently to some of these treatments. I think the phenotype is also sometimes a little bit different in our population. So yeah, it's great that this Society for Eczema Studies is being set up, and hopefully we can all contribute our expertise, our patients, in studies, and if we can collaborate on it, I think this would be great. So
thank you very much, Mark.
Thank you, Sandipan. So I hope you can see my slides. I'll be speaking on systemic and newer therapies for atopic dermatitis. These are my disclosures. And I'll speak a little bit on the burden of atopic dermatitis, which is actually very close to my heart because we do quite a lot of quality of life studies in Singapore. And then in terms of the treatments, I'll talk about phototherapy, just a few slides, because we still do quite a bit of phototherapy. And then the good old systemic immunosuppressants, which unfortunately now with the use of biologics becoming more common, we are finding the use of systemic immunosuppressants getting less, but I think it's still a very important armamentarium in treating our patients with atopic dermatitis. And finally, I'll talk a little bit on biologics. We've used our practice on using biologics as well as small molecules. I'll just like to emphasize also that a lot of times most of the patients do not need the second and third line treatments, as Dr. Thomas had described. Really 90% of patients do very well with just topical treatments, and if they are, well educated on the use of topical treatments, they're compliant, you do get quite good results, in 90% of the patients that we see with atopic dermatitis, and usually less than 10% of patients we need to go on to treat with more systemic therapies. Yeah. Okay, so I think we all know that, atopic dermatitis is very, very common, and in Singapore we see it in more than 20% of children and adolescents. It makes up about 50% of the load of our patients in our pediatric dermatology clinic. And even in adults, we see it more than 10%. I think Dr. Sanipan had mentioned that in India it's about 8%, so slightly lower than in Singapore. But we also see quite a high and increasing prevalence in other Asian countries as well. And I think the problem is we are not only seeing a very a higher prevalence of atopic dermatitis, we are seeing more patients with more chronic as well as more extensive, more severe disease now, at least in the past 10, 15 years as compared to previously. And even though atopic dermatitis, doesn't kill a patient, it does kill a lifestyle. And I find that a lot of our severely affected patients with atopic dermatitis in Singapore especially are very affected in terms of their quality of life. They also spend a lot of money trying to treat the atopic dermatitis. They're tired all the time, and even in the family, the parents are also affected, the siblings are also affected. And in this study that we did, we can see that the more severe it is, the more impact on the quality of life. And as I said, it's also very, very expensive to treat patients with atopic dermatitis in Singapore. We found in a study that the annual expense per patient can go up to almost $8,000 US. And this can range from $6,000 to almost $15,000 US per year. And the more severe the quality of life is affected, the higher the healthcare costs to treat these patients. I think over the next few years, we will hear a little bit more about the systemic comorbidities beyond the ones that we already know. So we all know about the atopic match, with the very close association with allergic rhinitis, asthma, as well as allergic conjunctivitis, but also food allergies. We also do see some association with eye disorders and gastrointestinal conditions. We are seeing much more, especially in Singapore, psychological associations such as anxiety, depression, attention deficit hyperactivity disorder, and even autism. However, I think over the next few years, we will see more studies coming up on the association of atopic dermatitis, especially chronic extensive atopic dermatitis with metabolic syndrome. We're already seeing that with psoriasis, but I think over the next few years, we will see more studies coming up linking it with conditions such as hypertension, diabetes, hypercholesterolemia, as well as cardiovascular disease. And I think with this association being stronger, it will give us, more impetus to treat our patients earlier and to treat them more optimally. When we look at the trajectory of atopic dermatitis in most of our patients, the good thing is that the majority of them do improve as they go through life. Initially, they are more severe in the first few years, and then once they go to school, come out to high school, and they do get better. However, there will be a smaller proportion of patients, if you look at the red line here, which follows a trajectory such that their disease can get more severe as they go through childhood, and it remains severe into adolescence and into adulthood. So it's really this group of patients that we really want to try to treat to bring them down, to a better trajectory in terms of their disease. Otherwise, they end up being really miserable adults or adolescents. So then going on to second, third, fourth line treatments, I thought I'd just talk a little bit about phototherapy. We do still use quite a bit of phototherapy to treat our patients. Most of our patients that we treat, we give narrowband ultraviolet B. And there are a few studies to show that, for most patients that we start, and these are usually moderate to more severe patients, you get probably about 60 to 70% improvement with phototherapy. And this is with narrowband ultraviolet B. For patients who have more thicker lesions, such as prurigo nodularis, we find that the use of combined UVA with UVB is quite useful. And if you can see some of these studies again, we get probably about 30 to 50% improvement with the use of combined UVA and UVB treatment. However, phototherapy can take some time to work, so we have to tell patients to be a little bit patient when they start on phototherapy. We do also use soap puva for patients with hand and feet eczema, and there's some studies here to show, again, probably about 50 to 60% of patients fare quite well with treatment with soap puva on the hands and feet. Definitely, psoriasis responds better to phototherapy, but I think for patients who are a little bit concerned about systemic immunosuppressants and they are really suboptimally treated with the topicals, biologics may be too expensive, phototherapy is still a very good choice. We did our own study looking at patients that were treated with phototherapy in our center. 15 patients, we used narrowband ultraviolet B, 66% showed improvement. And for patients that we treated with ultraviolet A with narrowband ultraviolet B, around about 55% showed some improvement. So we do find, both sets of patients do improve between 50 to 60%. These are some representative photos. So you can see here in a patient with rather severe eczema, narrowband ultraviolet B. This is after about 3 to 4 months of treatment. You do see an improvement, probably around EASI 75. This is a patient with a little bit more prurigo nodule-like disease, and you can see that we treated the patient with UVA with narrowband ultraviolet B, and you do find improvement after, again, 3 to 4 months of treatment. So going on to systemic immunosuppressants, so over the years we've used quite a lot of this. The 4 common ones that we use are cyclosporin, azathioprine, methotrexate, as well as MMF or mycophenolate mofetil. I do refer you to this article that we wrote on non-topical management of recalcitrant pediatric atopic dermatitis. Another article that we wrote, we did an observational study for pediatric patients that we treated with systemic immunosuppressants. We looked at 35 patients with a median age of 10 years and a median duration of atopic dermatitis was about 8 years before we started them on these immunosuppressants. So if you compare between cyclosporin, azathioprine, as well as methotrexate, the response probably, if you compare good response, they're almost equal, except that we had a little bit more response to azathioprine. When you add moderate and good response, I would say probably about 50 to 60% of them do get at least moderate to good response. Some side effects, generally it's quite safe in children and adolescents. So in our study, we saw 2 patients discontinued cyclosporin due to some side effects such as hypertension and gingival hyperplasia. There was a marginal increase in serum creatinine for 2 patients in cyclosporin, which eventually normalized upon dose adjustment. No patients on AZA or methotrexate stopped their treatment due to side effects. 2 patients on AZA had mildly elevated serum transaminases. 1 patient on methotrexate developed a bit of nausea. So you can see it's actually quite safe in the use for children and adolescents. So in terms of my own experience in the use of immunomodulators, I think it's important to consider the indication to start. So generally, these patients tend to have moderate or severe atopic dermatitis that is not responding to good topical treatment, suboptimal response, and already starting to have a bit of issues with quality of life. We try to hold off as long as possible until the child gets older because we are starting immunosuppressants from a young age. That is a concern for long-term side effects such as infections as well as cancers. We do try to hit them hard, and then once they respond, we then tail down the dose and we find the lowest dose possible to maintain a good quality of life. Sometimes you might have to go on for treatment for a few years. Cyclosporin tends to work the fastest, so if the patient is getting a flare, I tend to start them on cyclosporin. It works within 1 to 3 weeks. Sometimes I do combine it with oral prednisolone for 1 to 2 weeks for even faster results. However, there is some concern for long-term cyclosporin with the cumulative effects causing hypertension as well as renal disease. So we try to tail off by 1 year, but definitely we have patients who do quite well on cyclosporin, and we try to come down to a pretty low dose, maybe 1 milligram or 1.5 milligrams a day, and we can keep them for a longer period of time with proper monitoring. Azathioprine and methotrexate, I find, takes a longer time to work. So generally, I do tell patients that we have to give for a couple of months for it to work. So I would say it's probably not as good for those with acutely flaring atopic dermatitis, and maybe good for more longer-term management if you need to go on for more than 1 year. I do find methotrexate particularly good for teenagers as well as prurigo nodularis, and the doses that I go up to can be about 12.5 to about 17.5 milligrams per week. Yeah, we are using a little bit more of mycophenolate mofetil, which we find a little bit safer than azathioprine. I'd just like to share with you my experience with systemic antibiotic prophylaxis, something that we've given in our center for quite a few years now. We know that atopic dermatitis is associated with skin colonization with Staph aureus, and even in normal-looking skin in patients with atopic dermatitis, you do find that there's increased Staph aureus load. And in some patients, they just get this repeated flares due to infections where the skin becomes pretty oozy and gunky, and it just worsens the eczema as well. So there are some strategies that have been used to reduce the Staph aureus colonization infection, such as the use of intranasal epiricin, because the Staph aureus likes to hide in the nares. Bleach baths, topical antiseptic agents. However, the results have been quite conflicting. So also the use of systemic antibiotic prophylaxis in the literature is actually quite lacking to reduce these infective flares. So we did our own retrospective study looking at children and adolescents that were less than 18 years of age with moderate to severe atopic dermatitis who keep getting recurrent infective flares. We gave them oral cefalexin twice daily at about 16 to 17 milligrams per kilogram per dose for at least 1 month. And then after a month, we tried to tail it down to once a day, and then from there sometimes we keep it for about 4 to 6 months. So we looked at a total of 16 patients. Initially their IgA scores were 3 or 4, so quite severe eczema. Mean duration was about 141 days with the oral cefalexin. If you look at the results, the infective episodes requiring systemic antibiotics dropped from 2.5 to 0. There's also a reduction in the number of unplanned clinic visits to children's emergency, hospitalization days, as well as the amount of topical corticosteroids used. So I think we found that it's quite a useful adjunct to reduce frequency of infective flare patients with moderate to severe atopic dermatitis that keep getting recurrent staph infections.
Dr. Sandipan, I think Dr. Mark had, yeah, he's back in again. Yeah.
Some internet issue must be, yeah.
Oh, sorry, I'm back. Yeah, I just put myself on. I hope I didn't. Okay, I think I presented from here, right? Okay, so we do need some future controlled trials in the future to look at the effectiveness, adverse effects, as well as optimal dosage of this systemic antibiotic prophylaxis. So if anyone's interested in doing a study, please come and look for me. Okay, so finally, I'll talk a little bit, quite a lot on the use of biologics, which has been very exciting over the last few years since we started using it. Of course, the first one that we know of is dupilumab. This targets an IL-4 receptor that blocks both the IL-4 as well as IL-13 signaling, and we do know that the Th2 pathway is hyperactivated in atopic dermatitis. So dupilumab blocks the entire Th2 pathways, very good efficacy and well tolerated. So far, it's been approved by the FDA, EMA, and HSA, which is the Singapore medication authorities for use in adolescents and children from 6 years and above. First studies came out in 2014 in adults with moderate to severe atopic dermatitis. If you look at the SOLO 1 and SOLO 2 trials, patients who were given dupilumab fared much better than patients who were given placebo. And they had longer term studies looking at the use of dupilumab up to a year. This was in adults, and you can see that patients do respond quite fast in the first few weeks of treatment, and they reach, sometimes EASI-75 by the time they reach about 4 months of treatment, and it's sustained over the 1 year. Some patients even improve even after the first 4 months of treatment. So again, very good results long term. They have then done studies in adolescents, and this was published in 2020, looking at adolescents, again, moderate to severe atopic dermatitis, treatment over 4 months, and they found that significantly more MAP achieved an IgA of 0 or 1 and EASI-75 compared to the placebo. There was also significantly more patients treated with dupilumab that obtained higher percentages of EASI improvement, and not only objective scores, but subjective scores such as the pruritus index, CDLQI, and POEM in patients treated with dupilumab compared to placebo saw a significant reduction. In terms of side effects, most common side effects that we saw was conjunctivitis as well as injection site reactions. I do apologize, still got a bit of post-COVID cough. This is a study looking at more long-term treatment, 1 year treatment with dupilumab in adolescents. And similar to the adult studies, you do find that they do respond quite fast in the first 4 months, and then this effect is sustained until 1 year of treatment. Long-term side effects, again, quite mild and minor. Again, mostly conjunctivitis as well as injection site reactions. Then they brought the study down to 6 to 12-year-olds. This was a study looking at either a 4-week treatment or a 2-week treatment with dupilumab in patients 6 to 12 years of age. You can find that in terms of IgA improvement, it's significantly better compared to the placebo. Again, in terms of side effects, conjunctivitis and injection site reactions, the studies have gone down to even 6 months of age. So in this study, the latest one, also just published last year, they looked at 2 cohorts between 2 years to 6 years of age, as well as 6 months to 2 years of age. And they find that this was a dosing study, and they found that both doses at 3 or 6 milligrams per kilogram fared very well in terms of efficacy and safety, with the 6 milligrams one having a more lasting effect compared to the 3 milligrams per kilogram dosage. We did our own study looking at dupilumab for our children and adolescents with atopic dermatitis. So our patients were treated, and this was the results at 4 months, and you can see that the IgA scores, 83% of patients had more than 2-point improvement. 10 patients achieved at least either IgA1 or IgA2. In terms of mean EASI scores, about 2/3 of them achieved at least EASI 50 at 4 months, about 40% achieved at least EASI 75, and about 10% of patients achieved at least EASI 90. And not only were the objective scores reduced, but also the quality of life scores in terms of the teen quality of life as well as the child DLQI. These are some representative photos of our patients treated with dupilumab. This patient had an EASI score of 60 at the start of treatment, and you can see at 4 months, his EASI score has gone down to 10, so very impressive results. Another patient that started with an EASI score of 62. After 4 months of treatment, his EASI has come down to 25, so he's achieved at least between EASI 50 to EASI 75. This was a younger girl that was treated with dupilumab, started out at EASI 44, and after 4 months of treatment, you can see amazing results at EASI 6. In terms of adverse events, we had 2 patients that developed some conjunctivitis, but this was quite mild. We referred them to the pediatric ophthalmologist, and the conjunctivitis improved with increased frequency of lubricant eye drop application. There was 1 patient that developed this paradoxical head and neck erythema, which has been quite well reported in adult patients. This patient of ours developed, he was a 18-year-old patient, and so I think it occurs more in the adult patients. 6 months into treatment, what we did was we discontinued the dupilumab, and the paradoxical head and neck erythema improved. We restarted him on a slightly lower dose of dupilumab, and it did not recur. So now we've used the dupilumab for about 60 pediatric patients and counting. Youngest so far we treated is 3 years of age, and longest duration so far is about 4 years, and majority of patients are still on dupilumab. In terms of dosing, we do give every one of them a loading dose of 600 milligrams, and this loading dose really helps to bring down the disease very fast for all patients regardless of age and weight. And then we give them for and less than 30 kilograms, 1 vial every 4 weeks. There is a 200 milligram vial that's available. However, it's sold at about the same price as the 300 milligrams. And we find that using this dosage, where it's 2, 3, or 4 weekly, does save the patients, especially the younger patients, increased number of injections, subcutaneous injections, and they do quite well with the 4 weekly dosage. In terms of efficacy, we find that about 95% of patients achieve at least EASI 50. About 75 to 95% of patients achieve at least EASI 75, and between 50 to 75% of patients achieve at least EASI 90. And most patients do get very significant improvement within the first 4 months of starting treatment, and most patients will achieve maximum improvement at 1 year of treatment. So generally, we will treat them for 1 year with an optimal dosage, and then once they get better, we will discuss with the family and with the patient on reducing the frequency of dosing, such that the atopic dermatitis continues to be well controlled. Sometimes we go from every 3 weeks to every 4 weeks, and then every 5, every 6 weeks. Some patients even do it every 3 months. Some of them may require increase in frequency during some stressful periods, such as during exams. When switching from other systemic immunomodulators, we tend to overlap for about 1 to 2 months before we tail off the systemic immunomodulator. We do see a few patients with suboptimal response. I'd say probably less than 5%. Important to evaluate for possibility of confounding conditions such as Leptin syndrome, or the patient has a more psoriasis phenotype or PRP phenotype. And of course, importantly, make sure it's not cutaneous T-cell lymphoma, so we may need biopsies to exclude some of these other dermatoses. We do try to optimize topical therapies. We find that for some patients, when they improve on the dupilumab, their compliance with the topical therapies drop. So we do remind them to use the topical therapies as well, especially their moisturizers. Sometimes we consider adding adjunctive systemic therapies such as adding on therapy, cyclosporin, methotrexate, and azathioprine. However, do be reminded that the safety and efficacy of these combinations so far is not fully known. We'll probably need to wait some time before we can report on the safety of these combinations. In terms of monitoring, we started out doing some blood tests, but now we've found that it's quite safe, so we don't do any monitoring. In terms of safety, the most common side effect we find is mild conjunctivitis, especially patients with underlying allergic conjunctivitis. So we do have a low threshold to refer to ophthalmologists when they get the conjunctivitis. We do start concomitant eye drops for patients such as corticosteroid eye drops or TS natural, at least for the first few weeks or months when we start on dupilumab. In terms of vaccinations, patients on dupilumab can safely receive inactivated vaccines. However, for live attenuated vaccines, you probably it should be avoided or carefully considered on an individual basis and after discussion with the appropriate subspecialists. So moving on from dupilumab, which is still currently the main one that's been approved, there are other Th2 antagonists, and the two that are going to come up over the next few years, tralokinumab and lebrikizumab. These are specific IL-13 antagonists. Remember, dupilumab is an IL-13 and IL-4 antagonist, so these are specific IL-13 antagonists. And why IL-13? Because they found that IL-13 is responsible for many of the pathogenic effects, Th2 effects in atopic dermatitis. So lebrikizumab is still in phase 3 trials for adults and adolescents. We were part of the adolescent trial, and tralokinumab has been approved by the US FDA last year for atopic dermatitis in adults, but both have not been approved for adolescents. This is a study on lebrikizumab in adults with moderate to severe atopic dermatitis. I would say the results are probably quite comparable to dupilumab. And similarly, we do find in our patients who were on the lebrikizumab trial also response rate is probably about the same as dupilumab as well. In terms of tralokinumab, this was a trial in adults with a moderate to atopic dermatitis. Again, if you look at the results, they probably reflect pretty similar results to dupilumab, but so far it's not been used in the real world yet, so we can await approval, and hopefully we can use it in the near future. There's another new molecule. So far it's just called Aslan 004. This is a specific IL-13 receptor alpha-1 subunit that inhibits both IL-4 and IL-13. And currently it's undergoing phase 2 trials in adults. We are part of the trial currently, and hopefully in the next few years we will see trials going to for adolescents as well as children. Another exciting molecule is nemolizumab, which is an IL-31 antagonist. So IL-31 has been shown to be upregulated and is an important mediator of itch in atopic dermatitis. Currently, nemolizumab is undergoing phase 3 trials. And initially, the clinical trials showed significant reduction more in itch rather than clinical features of atopic dermatitis. But in more recent studies, it's been shown that in the use of nemolizumab in moderate to severe atopic dermatitis, there is improvement not only in the amount of itch that patients experience, but the signs of atopic dermatitis also improve. This is the EASI score over time. So again, a very important molecule to look out for over the next few years, nemolizumab. Finally, putting some words about systemic JAK inhibitors, the JAK-STAT signaling. I think Dr. Thomas has talked about this already. These IL-4, IL-13, what they do is that they activate the JAK molecules, and these JAK molecules dimerize, and they phosphorylate STAT6, which then goes into the nucleus and binds to promoters of IL-4 and IL-13 responsive genes. So JAK-STAT signaling is important in keratinocyte differentiation, Th2 cell differentiation, IgE class switching, as well as pruritus. So the JAK inhibitors have been found to have potent anti-inflammatory as well as anti-proliferative effects, and inhibits cytokines that are important in the Th2 pathway. So there are a few oral JAK inhibitors that has so far been approved. Baricitinib has been approved by the EMA in 2020. Abrocitinib has been approved by the US FDA just in January this year, and so far upadacitinib is also approved by US FDA just this year. However, these approvals are only for adults. We were part of the upadacitinib trial, and I do find that the effects of the JAK inhibitors are more robust than the biologics, such as dupilumab and lebrikizumab. Almost all patients do get at least EASI 90 improvements. However, it's also an oral, it's taken orally, so definitely easier to administer to children and adolescents. However, I think in terms of safety, there's increased side effects for the JAK inhibitors compared to the biologics. However, most of these side effects are seen more in adults compared to adolescents in the trials. So this was a trial looking at baricitinib. Again, very good results with 2 doses of baricitinib. This was for 16 weeks, and you can see improvements in EASI scores, as well as patients who achieve EASI 50 compared to placebo. This was a trial for abrocitinib. Again, pretty good results. I would say probably maybe better than dupilumab. Again, 2 different doses of abrocitinib. And baricitinib, which is the most recent one. Again, very good results in terms of EASI scores as well as IGA improvements. So just a final conclusion, atopic dermatitis is very, very common in children and adults. And really, we want to control them early because poorly controlled atopic dermatitis can lead to severe psychosocial dysfunction in patients and their families. So we really want to, pick them up early and treat them early before the onset of psychosocial issues. Most patients do improve with topical treatments, so always think of that first. I always start with topical treatments, optimize it, make sure compliance is good, avoid triggers, so that's so important. And however, if you find that they don't improve, do think of systemic treatment. So I think phototherapy does work for maybe about 50% of patients that you start on. Systemic immunosuppressants do work as well. Cyclosporin, azathioprine, methotrexate, as well as MMF. However, when these don't work, you may have to consider moving them on to a biologic. And currently, dupilumab has shown very excellent results, both in trials as well as real-world use in adolescents, adults, as well as children. There are new biologics that are coming out over the next few years, so that will increase our armamentarium to treat more severe patients. And of course, there are the JAK inhibitors that are also quite exciting and really provides us, better treatment options for our patients with more severe atopic dermatitis. And with that, I want to thank you for your kind attention. Just to put in a word about Asian Society of Pediatric Dermatology. If you're keen to join, that's our website. Membership is free. And also the International Society of Pediatric Dermatology, that's our website there. Dr. Sanifan and myself are part of the board, so do join us. Both societies do provide quite a lot of education opportunities. And so please go on and sign up with the 2 societies. And with that, I really want to thank you for your kind attention.